Dr. Denise Ejo, the CEO of Cornwall Cancer Foundation. I would like to welcome you to our Cornwall Cancer Foundation page. Our goal is to create an awareness of the challenges, support and guidance experienced in managing cancer care for sufferers, family, carers and friends. To engage with us, don't forget to subscribe to our channel. Click our notification bell.
Morning, doctor.
Good morning, Doctor. Good morning, everyone. How are you?
Over to you.
Great.
Are you alone today? Is it ladies and gentlemen or just ladies?
It's ladies, and it's International Women's Day too.
Same to you. I think, and we've got a woman on the platform again today, so yeah. I think we should be able to have some fun.
All right, over to you.
Yeah, sure.
Good morning, everyone, and thank you for joining us again today as we have a discussion on colorectal cancer. This month is colorectal cancer, so we'll be talking to Dr. Funmi Wuraola, who is a consultant general surgeon in Obafemi Awolowo University. Did I get that right? Good morning, Dr. Funmi. Yes.
Good morning.
Yes, so I actually did get it right. Sometimes I don't get it right, so let me just be very respectful. Now, so thank you very much, Dr. Funmi, for joining us today as we continue our discussions on our cancer awareness program. Today, we'll be talking to you, and I'm going to start very quickly as we go along. So, nice and easy question that would help the general public. Are you seated and are you relaxed?
Good morning.
Good morning.
Yeah, it's good to be here.
Your picture has come off. Go on, let's go. What is colorectal cancer?
Okay, just in a layman words, colorectal cancer just means a tumor, or let's say a swelling that is growing abnormally in anywhere along the intestine. We have the large intestine, we have the small intestine. So in the big intestine plus where our feces accumulates, which is the rectum. So any cancer that is, any lesion that is growing around that part that is cancerous is what is called colorectal cancer.
Nice and easy. Okay, but I don't know what this rectums and all that. That is what in English? So your stomach,
Okay, so in English, we have the stomach. The stomach is just where the food collects before it goes into the small bowel. Those are the smaller parts where the food gets absorbed, and it moves to the larger part of the bowel. So I don't know. I know this is a multinational stuff, but for my Yoruba people, they will understand the shaki and our body kind of parts.
Oh,
so
yeah.
that your roundabout part, that's the large bowel. So that's where anything that is cancerous that is inside the place is called colorectal cancer.
Thank you very much. You see, you made it in a layman's English. You see, sometimes it's not always necessary to speak too much English. Okay, so now the next question. What are the risk factors of colorectal cancer?
Okay, so we usually classify the risk factor based on things that I can change and things that I cannot change. So we talk about things that are modifiable and those things that we cannot modify. So when I talk about things that I cannot change, some of the predisposing factors that we cannot change is our gender. Being a male has a higher risk of having colorectal than a female. And that's something I cannot change. Another thing I can't change is my family history. So if I have a previous family history of colorectal cancer, that increases my chance of having colorectal cancer too. Or if I have some genes that are in my body that is from my family line that can predispose to colorectal cancer, those kind of things, I can change it. But those are factors that can influence colorectal cancer. But there are some factors that I can change. So we talk about things that I can change, like smoking. Smoking has been shown to be associated with increased risk of colorectal cancer. Another thing I can change is what I take into my mouth, what I eat. So excessive consumption of red meat have been associated with colorectal cancer. When I say excessive, sometimes when my patient comes to clinic and they said they do not eat meat, one thing I always ask them is that, Mama, how many meats do you eat in a day? They are eating a very small chunk. We are talking about people that eat kilos of meat at one sitting. So when you take excessive red meat, it has been associated with increased risk of having colorectal cancer. Other things that have been associated is our weight. If you're obese, obesity is actually associated with almost all cancers, just like smoking. So those are things that I cannot do anything about. People talk about when you consume foods that are sports, foods that have so many antioxidants and all that. So that have so many oxidative processes in them. Bad food, generally, that's where I will put it. We all know the food that is sports. Sometimes because you don't want it to waste, you eat them like that. So you are increasing the chances of colorectal cancer by what you're taking. So those are basically things that can increase the chances. And like I said, just like every other malignancy, it's not just one thing that increases your chance. It's usually a factor of things together. So that's why the ones that are in my purview to change, I should make effort to change them and leave the ones that is not up to me, like my gender and what's claimed from everyone. So that's basically it.
Well, thank you very much. You just hit something. I never, ever associated colorectal cancer with like things to do with genes and hormones and all that. Never. I don't think many of us really realize that. So you're saying if I come from a family that's had colorectal cancer, the chances of having it is high.
Yeah.
Wow, I never knew that. That is interesting. Yeah, well, you see, that's the point. If we don't know, you don't know what to prevent, and you don't know what your risk factors are, and therefore you cannot prevent yourself from actually getting these diseases. So let me go on to the next one. So surgery is the main modality of treatment in the management of colorectal cancer. Is that correct? I made a statement.
Yes, so I'll
have to be very careful, when you do this thing, you have to ask the right question. So I'm not a medic, So therefore, what is the role of surgery in managing colorectal cancer?
So I'll put it in two ways. Initially when I was talking, I talked about the colon, the large colon, and I talked about where our feces stays for a while before the call of nature comes and we go and evacuate it. So that area where it stays is what they call rectum. For colorectal generally, surgery has a major role, to be frank. For colon, surgery is very important, whether you are using it to cure the patient or you are using it to palliate the patient, depending on when the patients come. The same thing with in the rectum, so surgery is very important. But another adjunct in the rectum that is very important is radiotherapy, which we must not underemphasize the usefulness. And for both of them, chemotherapy is very important too. But since I'm a surgeon, I'm going to stick with the surgery part. So surgery is very important because you can actually achieve cure when you get it right. But one thing I always tell people is that we advocate that patient comes early. For patients that are coming for treatment early, you can actually take care of them surgically and your chances of survival is very high. But when patients are coming when they're already in obstruction from the tumor, or when the tumor had already leaked into the peritoneum, seedling everywhere, that becomes an issue. So the surgery you are doing at that time is not to cure the patient any longer. You're just using it to prolong their life and make their life less stressful, less of pain and all that. So the surgery part can be into two parts. It can be either to heal, cure the patient, or you are using it to palliate the patient. But unfortunately, majority of our patients now still comes at the stage where you are doing more of palliative surgery for them rather than using it to cure them. But I think the story is changing because of more awareness that we are seeing. So we are seeing people coming pretty early compared to before.
Oh, okay. So with the surgery, you have a better chance of actually succeeding.
Yeah.
And crossing the line. You see, sorry, I don't know. I don't remember if I said it. Because I live with cancer, sometimes I actually want to understand and process these things. Knowledge is power. So once you know what you're trying to navigate around. And everybody has a colon. So everybody
should be interested.
In one way or the other, yes, be affected by this. Okay. There is a procedure therefore called, now this is your colostomy. Colostomy. So what is it and when is it necessary then? Sorry.
I'm so happy that you're asking this because colostomy is one procedure that what we do basically, let me start with what we do in colostomy is that you are bringing a part of the bowel, the part of that large intestine that we talked about, the part of that roundabout, you are bringing it to the skin on the stomach, what Nigerians call stomach, but we call anterior abdominal wall. So you're bringing it out on that place. So that's where the feces will be coming from, not from the anus. So usually we do colostomy for different reasons. One, if you are doing some curative surgeries for a colorectal cancer, you might want to do a colostomy to protect, we've taken part of the place that has the tumor and you're going to join them together. So when you are joining them together, you want to protect where you have sewed together, that place that you have doing some tailoring. You want to protect that area. So you give a colostomy. For those kind of people, their colostomy is what we call a temporary form of colostomy. After the place you tie together, you suture together has healed very well, you go and return that colostomy. Maybe 3 months, 6 months after, you return it. That's temporary. I feel that is usually easier for patients to accept. But there's another one, especially for people that have rectal cancer. When they have that small space where the feces stay before we now go and evacuate, if we have a tumor that is growing there, and it's going to affect what makes us to hold our feces after we have removed, because God has put it in a way, there is a stopper. Let me put it like a stopper, that when I'm not where I can pass feces, that stopper will stay there. It will not make feces to come out. When I get to where I can pass feces, this stopper will relax itself and I'll be able to pass feces. But sometimes this cancer can affect that stopper. Or the surgery we are going to do, because we want to cure the patient, it might make us touch the stopper. And if you touch the stopper, the meaning is that the person will be passing feces continuously. He will not know. He will just be passing feces. So that means an adult has to be wearing diaper. It is stressful. The quality of life is not good. So to prevent that, we do what we remove the whole of that bowl where our feces stay. We remove that where the feces come out from, and the stopper and everything. We'll remove everything. And we'll now bring that other hand to the stomach so that where feces will be coming out from. So when we do that, that's a permanent form of colostomy. And it can be very difficult for patients to accept. I've seen people tell me that they would rather die than have that because they don't want to be going around with a stoma for the rest of their life. But I've seen I used to use one patient in particular as an example. I've not been to medical school. I've not even dreamt of going to medical school when this Baba was operated. He was operated 32 years ago. I still saw him in clinic a few months ago. It's fine. He had that surgery when he was in his 50s. Now he's in his 80s. He's lived the colostomy for that long. So it is something that we can live with and we can do well with. But like I said, we do it for different reasons. The third reason why we do it for is that sometimes people come in, the whole passage is blocked. We just needed to relieve the passage for them. But we cannot remove the tumor because the tumor had gone everywhere. So in that kind of case, you are just giving them a palliative stoma. So which is something that we can give. So but I need to explain this very well. I'm happy that you're asking me because we've had so much issue with people accepting colostomy. For people to know that colostomy is not the end of life. It actually helps you better and it gives you better quality of life compared to where you're coming from. So we should not always be tight-fisted and say, no, if you want to do colostomy for me, I'll rather that. I think that's not the best way to go about it.
Okay, now I'm going to go back to you because I actually do know someone who was diagnosed with colorectal cancer, yeah. And I can tell you, I know she lived a very, very, very fulfilled life. However, one of the things that came up then, and that we all struggled with was all the things you require. So you need a colostomy bag, right? Something like that.
Yes.
All those things that you need to make sure, because using a colostomy bag, I presume, requires you need to pay for that. There's a hygiene issue with it. There's a maintenance issue that comes with it. Can you just talk us through it? Because I never understood it. I just knew that she lived a good life, and the truth was that she was somewhere in Ogun State. Not capital, just normal. Yeah,
I get. So one thing about colostomy management is that, like you said, it requires some management because now you are recreating things the way they were not initially. So because we need a bag, there are different specialized bag that is made for the colostomy that fits into that hole perfectly. In fact, recently I was watching one group of people living with colostomy in the UK, and they were swimming with their bag. Somebody just made these very lovely bags for them that you can swim and you're not soiling the water, and it's just totally wonderful. In coming back to Nigeria, we don't have these bags readily. It could be difficult for patients to access, but that doesn't mean that we leave our patients just hanging. So we have done some modifications on the bag such that even a man that doesn't have so much fund can still be able to live a normal life with it. So our normal nylon that they use for making food, that small nylon, we can be improvised using plaster around it. So we teach patients how to go around it, how to keep the skin clean, how to be able to do it. And like the old man I told you initially, Baba uses nylon. He's been using that same nylon for 30-something years. And his colostomy site is perfect. So it doesn't 100% have to be the highfalutin things. Even the small things around us can be used, can be improvised to make a better living. So those are one of the things that we can use around. Of course, colostomy bags are better.
Thank you. Gosh, I love this. AIT did a lot, I'm telling you, because honestly, there's so much I learn, and I'm like, wow, this world, lots have happened, lots have changed. So still on this, my colostomy. Is colostomy temporary or permanent? So it's from what I understand now, it's both. It depends on where the patient is at.
Yeah.
And the patient will make progress irrespective, for as long as they follow the rules. Like I always say, for as long as we follow the rules. Okay, so can we now talk about the support and groups and platforms, things? I know of one that I really had put my hats up to, and I'm hoping to catch her. As you say, this is colorectal cancer month, so I no hope for me, but I'm going to catch her because she owns she runs the Nayola Colorectal Cancer NGO. But talk me through that, because that one. That's what I laugh about it.
I think we need to do better with having support groups for our patients, really. I think it's been so much of a mainstream hospital kind of things that we've been doing. Surgeons do the surgery, medical oncologists see, blah, 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 and we just left them hanging. But in recent times, I have discovered that bringing patients together, sharing what they've gone through, actually has so much effect. And in my hospital for now, we don't have a support group, as it were. So the kind of support group we have is an informal support group, where you ask the patient whether the patient is interested in sharing his idea with another person. So recently we are doing like a study for people that have had colostomy for more than 2 years to talk to us. How have they found? What are the things that we should have known from their home perspective? And you will be amazed about much things we've learned. Like we have a patient that have had babies even while on colostomy. We have people that have done so many good things while on colostomy, and they were sharing how they've been able to navigate it. So I said that support groups are very important. Like you said, it's only majority of the support group in Nigeria for now are run by non-governmental organizations. And I'm sure some hospitals too have some in-hospital based support group. Probably not so formal like ours too, there is an informal setting, but I think we can do better by giving people more support that they need. And I think another issue with the support group for us that we are just slightly getting to overcome is our cultural nuances. Sometimes when you ask a patient, are you comfortable sharing with another patient? Some tell you they are not, which I totally respect. And someone told me that I can if you want me to talk to the person on the phone, but I don't want to do it face to face because this person might know me and I don't want anybody identifying, which I totally understand, whichever way is convenient for us. So that's why I said, for now, we have an informal group, not a formal setting where everybody knows themselves and talks to themselves and all that. So that's where we are for now.
And thank you. I'm going to say to you from the perspective of someone who sits with it, that is one of the hardest groups. I think globally, there would always be a challenge. And especially with the Afro-Caribbean community globally as well. first and foremost, from the Nigerian perspective, it's not my portion. It's always going to stand out as to why you can't get through that aspect. And it's not out of anything. Sitting on the chair, I will not lie to you. It's actually very difficult to talk about the journey. I think I talk about it because I am still in it. And I think it makes a difference that I'm still doing it, and I'm now able to say, okay, comfortably, okay, I'm still here, just let's keep going. Yeah, at least there's hope. But I think I will tell you, it is very hard to do that support group thing. And I know that I refused to do it when I started. I refused it. So I'm just being honest with you. I was a bit afraid to do it. I was like, what if I'm not, who do I know is there? What are they going to say about me? What if they're going to say things I don't want to, So I think that is always the hardest one. In private spaces, it's a lot easier than in public spaces.
I totally understand.
No, I think we're sharing to the public now. So that some parts of the journey cannot be shared. And it's not because people don't want to share it. It's because of the emotions that go with sharing such experience. In your view, what is the recommended guidelines for colorectal cancer screening? And
so
let's start from there.
Okay, so I'm going to go to the guideline for screening in Nigeria. We have the Society of Gastroenterologists and Hepatologists in Nigeria. So they have a very lovely guideline, which you can all check up online. The name of the society, the short form is SOGIM. SOGIM has a beautiful guideline about how we should screen for our patients. And this is coming from our own epidemiological data that shows that we have colorectal cancer coming up in Nigeria like a decade earlier than is what is obtainable in the West. So if the West is saying we should screen at 50, it's better we start screening at 40 because our patient comes a little bit younger than that. And then the process of getting down to colorectal cancer itself, following what we call the adenoma carcinoma sequence, is about 10 to 15 years. So if I can pick a polyp like 10 years earlier, I might be able to reduce the chances of the person having colorectal cancer in the next 10 years. So usually the guideline recommends something. So there are some ways we can screen. We can use our feces to screen. We can do some investigations by using what we call a colonoscope or a sigmoidoscope. Those things are tubes that have camera on them. So from the anus, they will navigate and see the whole thing that is happening in the colon. So if colonoscopy is like the one that is recommended the most because that is done, if you do it for an average risk person. Who is an average risk person? People in the society, no family history of colorectal cancer, no family history of inflammatory bowel disease, no history of any other thing linking to them. They are just general population. So by the time they are 40, as they are doing photo shoots, they can give themselves a birthday gift of colonoscopy and just go and check their colon. So that's why I tell people, your 40th birthday photo shoots had some things to do. Check your breast, check your colon, check your prostate, because you are growing older now, so some things might not be working as they used to work before. So you can check the colon. And if you do colonoscopy and you are fine, he said that if it is well done, averagely you are covered for like 10 years if nothing was picked there. So, but there are other things we can use because of cost. Colonoscopy, we don't have so many people doing colonoscopy in the country compared to our number. If we are saying we are about 200 million, we need more people so that we don't overwhelm the system. So, but there are other things you can do. You can check the feces. It's just that the feces only have some things that can, if you see blood coming from other things or you had some food, it might not give the accurate result that is needed. So that's why if you are using feces, you have to do more, maybe like every 6 months, every year, kind of a thing. If you do what we call flexible sigmoidoscope, that one too, you are putting that scope inside. But this avoid thing has the left side and the right side. So this sigmoid scope can only see the left side. It won't be able to get to the right side. So because of that, but because majority of our cancer is on the left, they advocate that we can do that. And that can be done like every 5 years. And so those are the things that have been itemized for us to talk about. And one thing that I should make us know again is that there are some people that I must say, you must screen them. If you are a physician or you are a patient and you are 40 years and above and you go to the toilet to see blood in your feces, please use that opportunity to go for colonoscopy. It might not be something sinister, but it might be something. that might be calling your attention to something. So please, anybody 40 years and above, seeing blood in their faces, please and please, just say it's jedi. Don't just say it is because of you had sugary stuff. No, go and do a colonoscopy, and that will be better for you. And for people that have a family history, you have to start 10 years lower than the last person that had colorectal cancer in the family. So if the person that had it in your family is 40 years old, you have to start, and is a first degree relative, you have to start screening at 30 years old, 10 years lower than when the person started. So those are things that we need to know. Wow.
You see, this is further discussion. We're going to have to come back on it because time is always, it's very interesting listening to you guys, you doctors, man. I hear you. I want to say a very big thank you, firstly, to you, Dr. Fumi, for your time, for just educating us and helping us to navigate, especially those going through it at this point in time. So the month, it is Colorectal Cancer Month for all the organizations that are out there doing things for cancer patients. I put my hats up to you. Well done. Thank you. We appreciate you, all of us in the cancer community. We're saying to you, the doctors, thank you very much. We know you're working for us and we really appreciate the work you're doing. And to all our NGOs in Nigeria, I did mention Neola, but they're not the only ones. All those that are actively doing things this month to support cancer patients nationally in Nigeria, I also say well done and thank you. We really do appreciate you. I'm telling you from the bottom of my heart, we patients, we appreciate you. We appreciate you, doctors. So today I want to say a very big thank you to you all for joining us. And I want to thank AIT for a fantastic time and allowing us to continue to drive this cancer awareness in Nigeria to change the narrative. And hopefully with time, we will get there. You can find Comod Cancer Foundation on any of our social media handles, Comod Cancer Foundation on YouTube, Facebook, Instagram. We've got an email, and you can get information of what is going on every month on our spaces. We wish you a lovely day and we look forward to seeing you again in 2 weeks. Thank you very much for joining us. Thank you, Dr. Wura, for joining us. And I will chat with you in a few minutes. Thank you.
All right. Thank you so much, Dr. Dennis Ejo.